Hi everybody, welcome to the lesson where we discuss the approach to a hypopituitarism patient in an emergency situation. And emergencies are patients that are either show up in the emergency department or even a patient in the intensive care unit that has hypopituitarism but is suddenly decompensating. So first and foremost, let's talk about the things that we don't have to worry about. Thyroid hormone levels and growth hormone levels are not important in the acute phase, so we're not going to talk about them during this lesson. But what we are going to talk about is the two things that might kill the patient and are very dangerous. So we have to worry about adrenal crisis for one, and DI secondly. So let's start with adrenal crisis first. The first most important question that we need answered for all our patients is this patient on steroids? And if the answer is yes, then they need to be taking a stress dose that has to be given on the day that they started feeling sick. So the second thing we need to answer is if they did take that stress dose, and if they did take it, were they able to tolerate it? Many of these patients have vomiting as a presenting feature, so it's important to know if they'll be able to tolerate it. If the answer to this question is yes, then okay. But if they have not taken it, or if they were not able to tolerate that dose, then that patient needs an emergency stress dose as soon as possible. And the treatment aim is to actually over-treat the patient, is to overload them with steroids so that with one-time IV dose, as a stat solucortive dose, they're going to be covered for the steroid needs for the next 12 hours. And the way we base these doses is age dependent. A less than 1-year-old will take a 25 milligram one-time dose. A preschool kid will take a 50 milligram dose. 6 to mid-puberty, they need 100 milligrams as a one-time dose. And everyone above 14 should take about 150 or 200 milligrams as a one-time dose. So let me scroll down here and change gears to talk about diabetes insipidus. There's two things that can happen with diabetes insipidus. One is hyponatremia with sodiums as low as 115 to 120, so very, very dangerous. Or hypernatremia, where the sodium can go up as high as 170 or even up in the 190s. The questions that we need answered for all the patients that have DI is if they are on DDAVP, and if they are on DDAVP, what dose of DDAVP they're on. Also, how are they taking it? There are subcutaneous forms, intranasal forms, and oral forms of DDAVP. Especially with the oral form, where they're able to tolerate the last dose. Let me change colors here to signify how important this next question is. It's very, very, very important for us to know when the last dose was given. Another very, very important thing also in purple is the fluid status of the patient. Many of these patients will have a fluid prescription because they do not have an intact thirst mechanism, and many of them will have ongoing fluid losses, either diarrhea or vomiting or any other way. So the way that we evaluate these patients is we need a very good clinical examination, specifically focusing on hydration status. We need to review the vital signs with a focus on tachycardia or eventually hypotension if they're in shock. And then the labs that we need are focusing on hydration status, so a sodium level and a BUN. The severity of either the hyponatremia or hypernatremia has to be seen in the context of when the last dose was given, and also what's the fluid status of this patient. That's why these two are very important, because they help us figure out how severe the hypernatremia is. So let's quickly zoom out and scroll up where we can review the key concepts we talked about. For patients that have adrenal crisis, it's important to know if they're on steroids and if they took and tolerated stress doses. If not, they need a stress dose ASAP. This can be given as a one-time IV stat dose of solucortive, and the milligrams are age-based. For patients with DI, it's important to know if they're on DDAVP, the dose they're on, the route they're on, and if they tolerated the dose. The most important question of all is when was it last given, and questions regarding the fluid status. That's going to help us interpret the sodium with regards to these two factors and ascertain how severe the hypo or hypernatremia is. Thank you so much for listening. Make sure that you check out the other endocrine videos online.